Hello and welcome. I'm Steve Clemens. I'm editor-at-large of The Hill. Thanks for joining us for Diabetes and the Future of Healthcare Reform. This is going to be a deep dive into what the future of healthcare could look like for patients with diabetes. I'd like to thank our sponsors, the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition, for their support of today's event. As the next 4 years of healthcare policy take shape, it's a crucial moment for the 1 in 10 Americans. That's 1 in 10 living with diabetes for whom reform is not just a talking point, it's a lifesaver that could mean easy access to quality care. Are there improvements that can be made to Medicare or to Medicaid and to commercial insurance? How can we restructure our nation's healthcare system so that it works for everyone, particularly those with chronic conditions? We're going to be asking these questions and more. But before we get underway, a few housekeeping notes. First, I hope you tweet us at @TheHillEvents using the hashtag #TheHillDiabetes. Not too complicated. We're going to broadcast live, and we'll be taking your questions throughout the program. Just tweet them in, email them. My team will bring them in. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guests today have spent their careers working to ensure access to quality care for patients with diabetes and are joining me today for an in-depth discussion of what a reform of commercial insurance could accomplish. Dr. Satish Garg is professor of medicine and pediatrics at the Barbara Davis Center for Diabetes at the University of Colorado School of Medicine. It's a mouthful, but he's great. Dr. Garg is also the editor-in-chief of Diabetes Technology and Therapeutics Journal. And Cynthia Rice is chief mission strategy officer for JDRF, a global charity funding type 1 diabetes research. Cynthia is responsible for JDRF's advocacy to government and healthcare policymakers. Welcome to you both. Thanks so much. I mean, Cynthia, let me start out with you because I know JDRF covers a lot of things, but one of the things that really struck me in my dive into this subject, and I just want to be honest with everybody, you know, just scratch the surface of your friends. It's out there in your family, in your friends, in your neighborhood. I myself was a bit ignorant of the footprint of diabetes around me, and I just want to be open about that. But juvenile diabetes, undiagnosed diabetes, is huge. You know, when you look at 1 in 10, 34 million Americans, 7 million not diagnosed. And I'm just interested when it comes to thinking about moving this into a place, particularly reforming the cost side of this. Reforming the cost side also means getting more people in the terrain of care. So what would be the most important bits of this that you'd like to move?
Thank you. It's great to be here today. Look, unfortunately, too many Americans have difficulty accessing the drugs and the devices they need to manage this difficult disease. Fundamentally, diabetes care is preventive care. If people have the right care, then they can avoid emergency room visits and avoid having to have devastating long-term complications.
And so I get that, but I think the part of it is, you know, from a foundation perspective, what elements of the cost curve are you trying to adjust? I know that, and I don't know if you've seen it, but I've been reading over the last couple of days, the Democratic Leadership Council has this, you know, consensus set of findings, for instance, that it's talked about. You know, there are, many different dimensions of it, but part of it is, making sure that pre-existing conditions aren't lost, making, $1 is covered, those kinds of dimensions. What on that front do you think matters in your priority of concerns on the cost side?
Right. I mean, what matters the most is that people have access to insulin and people have access to the devices they need to dose insulin effectively. And so that means that health plans and employers should be providing those at low, predictable, out-of-pocket costs so that people with diabetes can access them. I mean, unfortunately, more and more Americans are in high-deductible health plans. And that means that they have to spend thousands of dollars out of pocket before their insurance covers any of their diabetes care. So, how are they supposed to stay out of the emergency room in that sort of circumstance? So, we need companies and we need health plans and we need employers and we need the government to really treat insulin and the devices to deliver it as the life-saving therapies that they are.
Thank you. Dr. Garg, I don't know if
Can I add something to this, which is
please go ahead.
You asked. There might be a simple answer. There is a bit of greed involved from all the parties, both the commercial payers as well as the companies who manufactured. In all fairness, I do a lot of studies for all the companies, but I have no stocks in any of the companies. But here's a very good example. If patients didn't have insurance and they wanted to buy a vial of insulin, it normally costs $400 to $500. The same vial of insulin made, or a pen made in the US or France, costs in Europe 1/10 the cost. And you go to India and China, it's only $5 or $10. So why there is so much greed and so much being charged to the Americans, I just don't understand. All the innovation happens here, all the research happens here, and however, Americans end up paying the most. It makes no sense whatsoever.
Well, as you look at these companies, Dr. Garg, and I'm going to probably show my generational distance from our younger generation. But, I used to watch the Schoolhouse Rock, how a bill becomes a law. And I had this idea that, somebody ought to make a similar version of how a drug gets a price. And kind of looking at, the journey that the little drug would go on, through the PBMs, through the insurance companies, from the pharmaceutical manufacturer, et cetera, to kind of look at that different dimension, then the rebates, et cetera. And it's a very confusing journey of that ecosystem of pricing. And I know it's a very big side of it, but I'm just interested in your insights, Dr. Garg, that if you were to kind of look at it, because I think a lot of Americans are just eyes glaze over when they hear about the complexity of drug pricing out in the marketplace, rebates, et cetera. What are the key principles? I mean, that's why I was reading the DLC principles of what they want to keep in place. They're fairly clear, which is if we have a system which is going to be patient-centered, well, then let's make it patient-centered. And let's look at where the dollars hit at that level and build from that around that system. But I'd be interested in whether you think I'm naive. that would be impossible.
No, Steve, I think you said very correctly. Let me take it even a step further. This is a life-saving drug. It needs to be made available, if not free of cost, at a very nominal cost. I gave you an example last time. University of Colorado. If anybody has type 1 or type 2 diabetes, all their drugs or devices, pumps, sensors, insulin, all drugs related to diabetes are given free of cost. Why can't we remove these barriers for people living with the disease? It's not their choice that they got type 1 diabetes or type 2 diabetes. It is an illness they got. We need to remove barriers so that these people can live happily and live a longer, near normal life. That's the barrier we need to remove. Whereas right now, the copays are so huge, $40, $50, $90, above and beyond. Every year, the commercial insurance companies end up changing what they want to pay for. For example, rapid acting, there is a Novolog and a Humalog. Same way on the long-acting, there is Basaglar, Lantus, Levemir, and the Tresiba. I just found out 2 insurance companies stopped paying as of this year, starting in a month ago. Blue Cross Blue Shield and United Healthcare will not pay for any more Tresiba, which is Diglipag, made by Novo Nordisk. They were paying all these years, now they suddenly stopped, which means we have to have our staff go through all the either prior authorization, which I usually know, or give them all the new scripts for the new insulin and find a new dose for the alternate long-acting insulin. That is really not the way system should work.
Fascinating. Cynthia, let me ask you a question. I mean, you've been in this arena for a long time, and you know the terrain well. Congressman Michael Burgess has said that we need to begin thinking about some of these large footprint chronic diseases in America and apply an Operation Warp Speed idea. And in fact, he said that's sort of what was behind the 21st Century Cures Act and things like, artificial pancreas, or I'm getting the terms wrong, and other things like this ought to be higher in the market. But what would be on your wish list of things with an incoming administration should be the high priorities to think about, changing the time curve, if you will, and the treatment curve of diabetes?
No, and 21st Century Cures has made a big difference because research does matter. We do, because of research and the investments in the National Institutes of Health and the work at the Food and Drug Administration, we do have new technologies, artificial pancreas systems, which make it possible for people to get better control of their diabetes. We have multiple versions on the market, and it's a real breakthrough for people with diabetes. But the challenges is making sure people have access to them. And so that's why we're focused so much on making sure that all the actors in the decision maker in the healthcare system, whether it's Medicare or private insurers or the companies themselves, are making these available in real time, without delay, without people having to go through lots of hurdles in order to access these therapies. And so it's essentially, it's critically important that the new administration, continue to fund research, continue to make sure that the Food and Drug Administration is accelerating innovation, and then make sure that people have access. We shouldn't have tens of millions of people still without health insurance or having to pay, extraordinary out-of-pocket costs so that they can't access the coverage that they have. So all of those things are critically important as we move forward.
Thank you for that. Let me ask you both a question, and I genuinely don't know the answer to this because I've talked so much about COVID, the pandemic, what's happening, the disproportionate impact that COVID hits. A lot of the same patterns are exactly the same for diabetes. And Dr. Garg, I'm interested in whether you think COVID has helped raise awareness of the healthcare ecosystem and where diabetes fits in that, and treatment cost reform, or whether it's been a distraction that has harmed the terrain.
No, it definitely has brought to the forefront. I'll tell you why. Because most of the data shows that if you get COVID and you have type 1 or type 2 diabetes, you're at high risk of dying, needing the ventilators, and being in the hospital. One of my patients, unfortunately, had to be in the hospital and was on a ventilator and ECMO for at least 6 months. So it is unfortunate. There is, like this Monday when I saw 14 patients, not a single person didn't ask me about the COVID. What is my risk? What should I do? It has brought to the forefront. Because people are worried about COVID pandemic and the vaccine not being available and therapeutics, we don't know how well they're going to work for people with diabetes. It is so pertinent, Steve, that we need to make telehealth available and be reimbursed at the same level as we are seeing patients in person. In all fairness, majority of the care for people with diabetes, if run through devices like continuous glucose monitors or pump, can be managed remotely, so that out of their 4 traditional visits a year, 3 could be easily reimbursed through telehealth. That'll alleviate patient stress and exposure to coming to the hospitals or to the clinics and be exposed to others for the COVID. And that is the sort of change we need to see. But right now, as I said it about a month ago, many insurance companies are not reimbursing the televisits. So we need to take away the barrier. And to take a step further, Medicare does not reimburse.
Right.
They reimburse the telehealth, but they don't reimburse interpretation of continuous glucose monitor, which is how we are delivering the care. So it's very unfortunate how the piecemeal steps are being taken.
Satish, last time you and I spoke about this, you said the same thing months and months ago. Exactly. I went out and looked at it. It's been the biggest behavioral change, right, in monitoring telehealth, the synthesization of, digital technology to do this. And I can't find a Republican or Democratic member of Congress that's opposed to this. They said, it's been game changers for their constituents. But still, so much of it is going to expire when the emergency of the pandemic is called off, and you're already seeing, business go there. So I'm glad you're underscoring that, and people should know that this world that we've kind of created is, at least right now, officially a temporary one on that. But let me get...
not only that, Steve, also just to add to that, this COVID is not going away.
Right.
It's going to be with us for some time. If we are dreaming that whole population is going to be vaccinated by next spring, we are out of luck. We'll be
Right.
barely touching the surface. And not only that, a lot of people have delayed showing up for their new onset type 1 diabetes. And if you look at the data, many people ended up going to the ERs with DKA, diabetic ketoacidosis, because they postponed, they were scared of going to the doctors. So we need to make things easier for people.
Thank you. Cynthia, I'm going to give you the last word on this, but as you're responding to the same question, I'd just be interested in whether JRDF is out there trying to underscore the parts of patient health and the dependability, because I know that there's a wobbliness in service as we consider moving from a value-based healthcare system, a wellness-based healthcare system, from a fee-for-service system. There is a wobbliness in that for people. Are you trying to underscore again that we're able to continue to give patients that patient-centric, dependable service they know that they need?
Absolutely, and I endorse what Dr. Garg said about telehealth. It's been a life changer for the diabetes community, and it's important that it continue even after COVID. Look, I think all of these issues, we need change throughout the healthcare system so people can have access to what they need to stay healthy. And we have a very fragmented healthcare system in this country. And right now, employers and health plans and the government can take actions that can help people have access. It's critically important that people with pre-existing conditions, such as type 1 diabetes, continue to be able to get insurance and that pre-existing conditions are protected. It's critically important that people have coverage and that coverage actually covers what they need to stay healthy until research brings us cures for these diseases. So all of the things we've talked about today are incredibly important, and we look forward to working with the new Congress. I know later in the program you're going to have two of the leaders of our diabetes caucus on. There is bipartisan support in Congress for both research and access to diabetes therapies, and we made a lot of progress, but we have a lot more to do.
Well, I really appreciate that. I want to thank Cynthia Rice. I'm sorry, go ahead, Satish.
Just one more word.
Sure.
Why can't these Congress people look at what University of Colorado has created? For people with type 1 and type 2 diabetes, there are no copay. Diana DeGette knows this very well. Her daughter has type 1 diabetes. So why can't they look at some of these institutes or the big payers who are taking charge of this? Why can't they take that sort of a model?
Satish, since you're helping to open this program today, I'm going to ask Tom Reed and Diana to get that question. So you've already pre-planted it. We'll go to that. But it's always a pleasure to talk to you, Dr. Garg. Dr. Satish Garg, Professor of Medicine and Pediatrics at the Barbara Davis Center for Diabetes at the University of Colorado. Thank you for always taking our call on this. And Cynthia Rice, Chief Mission Strategy Officer of JDRF. Thank you so much for your insights. And I hope that we can keep talking about this subject, but in a way where we begin to track. I always feel like, what have we accomplished with these things? Are we going to be able to track some incremental progress forward? Are we moving in the right direction? And that's what we should be measuring ourselves on. So thank you both so much.
Thank you.
Thank you.
Bye-bye.
And now our second panel is going to discuss possible reforms to Medicare and Medicaid. This is for a lot of wonks that are really into this. So I'm looking forward to them just telling us how to solve these problems. Kelly Close is the founder and chair of the board of the Diatribe Foundation, a nonprofit dedicated to improving the lives of people living with diabetes and pre-diabetes. She's also the founder of Close Concerns, a healthcare information firm focused on diabetes and obesity. I love anyone that's involved with literacy on these subjects, and sign me up too. Dr. Marie McDonald is the director of the diabetes program at Brigham Health, where she provides clinical, academic, and administrative leadership of the hospital-wide diabetes program. And finally, Dr. Gary Puckrein is president and CEO of the National Minority Quality Forum. Dr. Puckrein has long worked to eliminate health disparities for racial and ethnic minorities through data-driven initiatives. Dr. Puckrein, it's great to see you again. Let me start with you. We've had the conversation before. I'm always grateful as well that you take our call to join us. But as we sit here again, I sort of feel like we're at a political inflection point. So many political inflection points are also economic inflection points. They're opportunities to scramble things in new and different ways. What do you think the equities are that we have to get right on the fight against diabetes and dealing with the fact that this disease doesn't hit this country evenly. It hits very unevenly, but would love to get your insights.
Yeah, I think the moment has come where we should start talking about reimagining CMS, the Center for Medicare and Medicaid Services. It is actually fundamentally broken. It acts more like HCFA, which was the predecessor agency, because it's focused on financial risk and not patient risk.
Right.
So when you look at diabetes, for example, 60% of everyone with diabetes in the Medicare program goes to the hospital or the emergency room every year. An African American with diabetes and ischemic heart disease has a 90% hospitalization rate. 38% of the Medicare budget is being spent on people with an underlying condition of diabetes, and the program has not taken leadership on remedying this problem. We have to reduce diabetes-related hospitalizations. We have to reduce the risk of people going to the emergency room, getting disabled, and dying for diabetes. And Medicare and Medicaid has to lead the way, and the program right now is fundamentally broken. It's not doing it.
Well, thank you for that, and you know, that's a big challenge, but one I think is very important. Kelly, tell us how we solve. I saw you smile when I said I'm going to give you all the power in this to fix this. What do we need to do in Medicare and Medicaid? And I got to tell you, because one of the things I really liked about the profile of what you're doing is you're also committed to literacy. I mean, if you have this, it's like a journey through a never-ending morass, a labyrinth. I mean, I feel, and you know, maybe other viewers see it differently, but I would love to get your sense, Kelly, on how you would shift things, what you would prioritize, what do you think needs to be changed?
Oh, yeah, thank you. And I mean, what an honor to be here. And it is, Diatribe has this priority and these sets of priorities in and around literacy because of leaders like Gary, because of leaders like, you know, Dr. McDonald. So we are very lucky that we get to see them and that we know that, I mean, we absolutely have to start with the science and the data and the technology, and we must be able to get there. I was really happy seeing the head of the ADA, Tracy Brown, standing in the Rose Garden a few months ago, and that some work has been done on insulin for seniors. And it needs, but it needs to be, we need to think for everyone, how can the health be there to start with, and that we're working on kidney health, on heart health. There are amazing things that have happened on the scientific front in terms of that. And we need to make sure, you know, that just like Cynthia said, you know, that the access and affordability, the coverage is good. And then to make sure that the affordability is there, so all of us out of pocket is not so stressful. And it is healthy foods, you know, it is WIC, it is school lunches. It is multi-stakeholder work. We now have, I think, continuous glucose monitoring, Medicaid coverage of some sort in 37 states. We need to figure out where is it the best and use that as the model. And use that as the model for GLP-1 and for SGLT2s. These are classes of drugs that allow people to lose weight, to help their glycemic control without becoming hypoglycemic. They reduce heart risk. I mean, 10 years ago, none of us would have thought about taking medicine to reduce heart risk. That is how we get back to what Dr. Garg was saying and keeping people out of the hospital and so forth. I would hand it over, you know, to Dr. McDonald and see what else she would like. And again, to Gary. I mean, Gary knows who needs what, and we all better watch the census data and the zip code data that he will be coming out with at National Minority Equality Forum. We need to be watching that super closely.
Thank you, Kelly. And I got to say, I'm just so impressed with you walking during this conversation. And I'm going to try and start. It's going to be my new ask, maybe for Christmas from my employers here, because it's a really inspiring thing to see you do that. Let me go to Dr. McDonald and ask her, you know, the same question of, you know, what would you do on the reform front? But let me also ask you, Dr. McDonald, are you familiar with the consensus statement of these leading diabetes groups on some of the reforms they've looked at that really deal with, I mean, honestly, they deal with pretty, I mean, I'm editorial, so I can say this, but pretty common sense stuff when it comes to rebates when it comes to patients getting on the front end of the dollar on making sure that, core services that have been affecting people's lives, continue as we sort of see the healthcare system evolve. And so I'm just interested both in answering, what would you do to reform Medicare and Medicaid on this front? But two, why are these principles? I mean, I always wonder when somebody puts out a bunch of principles and said, here's our consensus statement, I ask, why is gravity so hard to get there, right? So what's going on?
Right. Yeah, we have, especially in COVID, it has shone this light on the fact that we need to meet patients where they're at. And I think a lot of the principles we're trying to infuse into CMS and their new policies has to do with that. Patients are at home most of the time. And our seniors, actually, the prevalence of diabetes is rising faster in our senior population than in any other population. And they become more complex as they get older. And as we heard from Gary Puckering, that these patients are in the emergency room way too often. So why don't we take the opportunity now to really identify that population, make it easier for us as providers to provide care in the home, or even provide consultative services in facilities where they're living, if they're not at home. The point being that there are too many barriers for us to provide care for the patients where they're at. Another example is a program we have worked on for many years, trying to capture patients who do come to the ER and prevent them from a long hospital stay. Many of our patients are admitted to the hospital because at that time and moment, there's nobody there to catch the football with their diabetes and say, I know, Mr. Smith, you're having trouble, your blood sugar is very high, but if you come into this program and you can stay at home and do this, you will be okay. And you don't need to stay in the hospital and sit and watch TV and be fed French fries, which is unfortunately what the hospital looks like for many of our patients with diabetes. And Kelly knows this. So I'm going to say simply, Medicare needs to, and CMS needs to support clinicians to take care of patients using telemedicine, remote glucose monitoring, and also just help us coordinate care with the acute care services to make sure patients are not lingering in the hospital. It's one of many, and I think the cost of medications, I was just doing the math on the recent data. If you take 40 units of insulin a day, which is a pretty average dose, out of pocket on average, that's about $400 a month. And there are many patients who don't have the money for that. They don't have the insurance for that. Right. And this is why they're rationing insulin, rationing medications, and they end up in our hospitals. So I'm very passionate about keeping folks at home with their families and safe.
Well, let me ask you just another question. I want to take a question from our audience that has come in, but I want to ask you just quickly, the three of you. And again, this is just my own experience. A former journalist colleague of mine, Olga Kazan, once wrote about the Baltimore area and a superstar woman and her family, lots of diabetes, lots of other chronic conditions, looking at parts of Baltimore where there were 20 years age difference in life expectancy between one part of Baltimore and another part of Baltimore. And they're sitting right next to Johns Hopkins University. And I guess my question is, despite the various reforms we have in Medicare and Medicaid, what is the state of play with research universities, with these large health centers? And I don't mean to typify them all in the same way, but is the relationship between those great institutions and on-the-ground healthcare and going into communities where it is just a lot tougher, and you have people not going in for care because of these speed bumps, these costs. Do you think that we need to focus? I mean, there's one look to look at reform, another side to say, we've got places of excellence in the country that aren't reaching out the right way. So this is sort of a pet question of mine. Kelly, what are your thoughts?
Well, I love hearing just your focus and passion and commitment to everyone doing as well as possible, right? And I mean, hey, the research universities are doing they're doing a lot of really good work. I think as we listen to Dr. Garg, I mean, the telehealth making sure that the reimbursement, I think this is my husband. Hi, Johnny. Sorry, guys. But really making sure that the doctors are set up to do as well as possible. I mean, Dr. McDonald, that she went into this area, and Dr. Pucker, like, they're doing labors of love, but we need to make this oncology. We need to make this many other areas that are going to bring people in. And for where the science is, there are so many better things to do. But Gary is, he can tell you, as you've heard from him before, you have to get everyone into the trials, and you have to make sure that no one is left behind. And for some people, they don't even have broadband access, I think looking at innovative ways of reaching patients and asking them. A lot of them are online and a lot of them aren't.
Right. Thank you. Gary Puckrine?
So, it's always a challenge because healthcare is a deep collaboration. There are a lot of pieces that go into healthcare. So it's hard to single out one problem, but let's give an example. We have these new CGM devices, time and range. They're helping people manage diabetes. My grandson had diabetes. I remember taking him to the beach, and I felt like someone who'd given me an automobile with no gas tank, with no gas gauge, right? So every once in a while, I had to stop and stick his fingers in and try to figure out whether he was his blood sugar level was about to collapse. CGM solves that problem, right? It helps people with diabetes manage their disease. Yet and still, it's very, very hard to get a CGM in the Medicare program. Minorities do not get a CGM in the Medicare program by the data, right? That is a health disparities right now that's going on in the Medicare program, let alone the Medicaid program, where we could control diabetes. So it's hard to look at the academic centers and say, that's a problem area. I think really, and what I'm getting at here is, we have to decide that we want to reduce patient risk throughout the healthcare system. That when somebody comes into the healthcare system, the purpose is to reduce their risk for a hospitalization, for an ER visit, for disability, for mortality, and not focus on financial risk, right? So we've prioritized the system to look at financial risk, and what ends up happening is that we elevate patient risk. We put them all at risk because we don't make available the technologies that will reduce their risk across the healthcare system. And that's why they're going to the hospital, is because it's the way in which we've built our healthcare system to focus on the financial risk and not what's happening to patients.
Thank you for that. Marie McDonald, before you jump in, I'd love you to answer my question, because I know you're going to be great at it, but I also want you to ask the question that we have from our audience member in with it. So let's hear from Michelle Oshman.
Hi, my name is Michelle Oshman, Vice President for External Affairs at BIO here in Washington, D.C. I'm wondering, given the disproportionate impact that diseases like diabetes and its comorbidities, namely heart disease, have on minority communities, how do we ensure that we have the right regulatory and policy environment in place to incentivize new treatments and new cures for patients who need them? So,
Dr. McDonald, it's two easy questions.
Yeah, right. Thanks. Well, I'm just going to say the first question you asked about the academic institution and some of the disparities we see right around those institutions, I think it's complex and probably more a reflection of what we're seeing in urban environments and social determinants of health, which are just, I think, more highlighted in populous areas around in urban areas. And we need to address them. And I'm thinking of the CMS model. To give credit to CMS, they did try in 2015 to lift up this chronic care management model where they would pay for up to 90 minutes of non-traditional face-to-face care. So not face-to-face, rather, either virtual on Zoom or on the phone. But the challenge of getting reimbursed for that, just like we see with CGM, is so high that many programs aren't adopting that strategy. But that would be a way to reach patients where they are in the community and not put the stress on them to find us once again. The second question is how to make sure that patients get the treatments they need. Is that what I'm hearing with that
it's
question?
basically, yeah, what Michelle Oshman is asking is how can we get the regulatory and policy environment shaped in a way that there's an incentive for new treatments and new cures, so part of the question is not just, what we were doing in the past. Part of it is, and this is always the tension, right? The tension is innovation, new treatments, new risks moving forward, but also keeping it affordable and high access. And so I'd love your insights. She would love your insights on that.
Right. I'm going to just say that we need to we have innovations that have not been put into play with our patients. We need to actually look at why that's happening. I think this is the moment, and Kelly's shaking her head. How do we make sure that the very now standard practice of CGM is in the hands of every single patient with type 1 diabetes, and you could argue every single patient on insulin? It costs the same to use 4 finger sticks a day, these painful finger sticks, than it does to use the newest, one of the newer, simpler CGM devices. It's the same cost as from what I can see. So why are we not doing that? How do we change the regulatory environment? I think that there has to be some more listening to the clinicians and having us sitting at the table, more people who are actually taking care of patients sitting at the table, and then listening to Kelly, who advocates for patients themselves. And Gary bringing in the social determinants of health and making sure everybody understands that there are barriers between patients and technology and medicines that we don't understand. We don't understand necessarily why these biases exist or how to get rid of them. But we need to know that they're there. So break them down, make it easier. One less phone call or email or fax would be a blessing for all of our patients just to get what they need.
Well, thank you. I wish we had more time. I love. We'll give you 10 seconds each, Gary and Kelly. Go ahead, Kelly. Yeah.
Also, using Medicare, not just to have CGM for people on the most intensive insulin, but anything that is causing hypoglycemia. Sulfonylureas, this is the next step.
Well, that's great. Gary, 10 seconds for you, my friend.
My word is focus on reducing patient risk. Activate people like Kelly and Dr. McDonald, allow them to focus on reducing patient risk. I think we'll have outcomes that we'll all appreciate.
Well, I want to thank you. I mean, I really appreciate this conversation, and I feel better that we had it, and I hope we can do it again. Dr. Gary Puckrein, CEO of the National Minority Quality Forum, Dr. Marie McDonald, the Director of the Brigham Diabetes Program, and Kelly Close, founder of the Diatribe Foundation. Thank you all so much for joining us today.
Thank you.
Thank you so much.
And now it's time for the sponsor perspective portion of the program and a message from the sponsor of today's event, the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition.
Hello, my name is Marilyn Serafini, and I'm Director of the Health Project at the Bipartisan Policy Center. Our mission at the BPC is to foster bipartisanship by combining the best ideas from both parties. And yes, believe it or not, bipartisanship is still possible. The panelists you're about to meet represent a group of 13 nonprofits that came together over the summer to develop a consensus statement on healthcare reform for people with diabetes. Our panelists are George Huntley, CEO of the Diabetes Leadership Council, Kate Thomas, Director of Advocacy for the Association of Diabetes Care and Education Specialists, and Christina Roth, CEO of the College Diabetes Network. Let's start with you, George. The Diabetes Leadership Council spearheaded this project. Could you please share a bit about yourself and the council and why you felt this was an important project?
Sure, Marilyn, thank you. I've been living with type 1 diabetes for 37 years, and in my day job, I've been the plan administrator of a self-insured health plan for over 22 years. I'm currently, as you know, the volunteer CEO of both the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition. The Diabetes Leadership Council is a group of experienced leaders from the diabetes community who are passionate advocates for people with diabetes. We're a nimble policy shop that gets involved in issues at both the federal and state levels. DPAC is a coalition of thousands of grassroots advocates from across the country who make their voices heard through our Click advocacy engine. Together, we are able to provide federal and state legislators with timely expert policy input as well as passionate patient stories to make the issues real. We were very pleased to have worked this summer with an amazing group of nonprofit partners in the development of the consensus statement on U.S. healthcare reform for people with diabetes. The pandemic has exacerbated the gaps in our current system, and it is our hope that the next Congress will take up the important task of closing these gaps. We prepared this paper to provide tangible recommendations for both commercial insurance and the Medicare and Medicaid programs that can improve health outcomes, lower patient cost, and lower the overall burden of diabetes on the U.S. health system by reducing the costly complications that result from uncontrolled diabetes. Diabetes is the ultimate you can pay me now or pay me later disease, and the U.S. too often opts for pay me later. A person with diabetes must have affordable access to the medicines, devices, education, and services they need to be successful in managing their disease. It can't be a function of socioeconomic status. Hopefully the panels today have illustrated some of these points. And I would like to briefly thank the organizations that came together for this important effort. In addition to the DLC and DPAC, we partnered with the Association of Diabetes Care and Education Specialists, Beyond Type 1 and Beyond Type 2, the Certified Board for Diabetes Care and Education, Children with Diabetes, the College Diabetes Network, the Diabetes Dietetic Practice Group of the Academy of Nutrition and Dietetics, Diabetes Sisters, the Diatribe Foundation, JDRF, and T1D Exchange. I'd like to personally thank them all for their valued input. Now, the consensus statement can be found on the DLC website at diabetesleadership.org. And Marilyn, thank you again for your help in moderating this session today. It is so greatly appreciated.
Thank you, George. So let's turn now to Kate Thomas with the Association of Diabetes Care and Education Specialists. Kate, could you please tell us about your group and what you'd like to highlight about health reform needs from your group's perspective?
Absolutely, Marilyn. And thank you so much to George and the DLC and DPAC for really putting this together. I think it spoke to the need within the diabetes community to really come together around some of these policies concerning healthcare reform and put together a document that we could all get behind and develop a strategy to take this both to Congress and to the administration and to other stakeholders to speak with this collective voice on these important issues. And so I am the Director of Advocacy at the Association of Diabetes Care and Education Specialists. You may know our organization by our previous name, the American Association of Diabetes Educators. We went through a rebranding in early 2020 to better reflect our membership and the role of our organization in healthcare. We're an interdisciplinary membership association dedicated to improving prediabetes, diabetes, and cardiometabolic care by optimizing this care and reducing complications. And we represent over 12,000 diabetes care and education specialists. And these individuals include nurses, registered dietitians, pharmacists, and others working to achieve these shared goals. And so we've been having a lot of conversations, as I mentioned, with our members about some of the challenges that we're seeing at the practice level, given that we do represent providers that work with people with diabetes. And George so eloquently captured a lot of the priorities that our members were seeing in terms of ensuring that all people with diabetes have access to the care that they need. And one of the areas that we're most interested in, and so glad to see this consensus statement reflect, is changing policies around diabetes self-management education and support, and diabetes self-management training, which is how it's referred to under the Medicare benefit. And we really believe these series of policy recommendations will help to change this benefit and increase utilization of the benefit and reduce some of the barriers that we're seeing there. So thank you, Marilyn. I'll turn it back over to you.
Thank you, Kate. So now let's turn to Christina Roth, founder of the College Diabetes Network. Christina, you have an amazing story on providing programs for students leaving home for the first time and having to deal with a chronic disease, as well as a new educational environment. Tell us a bit about the network and what you hope the review of health reform could do for your constituency.
Absolutely. Thank you so much, Marilyn. As Marilyn mentioned, my name is Christina Roth, and I'm the Chief Executive Officer of the College Diabetes Network. I've also lived with diabetes for 15 years myself. And with CDN, we're focused on young adults with diabetes across the country to help them be motivated and equipped to live a healthy life, to pursue their dreams without compromise. And that is so much of what connects our mission to the work that we did with our partners around this reform resource. Is our young adults are at a point in their life where it really is a pay now or pay later. But the choice to pay later also takes away the productivity of some of the best years of their lives. So what our young adults are fighting for and want you to consider is investing in them and their health now, so that they can be the citizens that they want to be and have the productive lives that they can live. So speaking as an advocate for young adults with diabetes, I want to leave you with the fact that young adults with diabetes have some of the most disproportionately high A1Cs compared to any other population. And yet, if an intervention happens now and supports young adults through this time, they have years of life ahead of them of productivity. And they want that productivity. So as you read these recommendations and you think of this consensus, please think of the people behind this and how desperately they want to have access to healthcare so that they can contribute to society and be part of everything that we're all working for.
Thank you, Christina. And thanks to all of our panelists for your hard work to develop this consensus statement on healthcare reform for people with diabetes. And thanks to you, our audience, for joining us at this session.
Maryland Bipartisan Policy Center, thank you so much for that segment. We really appreciate it. It's now time to hear from two people responsible for crafting the policies needed to improve access and affordability of care. I've got Representatives Tom Reed and Diana DeGette. They're both co-chairs of the Congressional Diabetes Caucus. It's a great pleasure to have you both here. Diana DeGette was the author of the 21st Century Cures Act, which we've discussed so much this morning, and played a key role in crafting the Affordable Care Act. In addition to co-chairing the Diabetes Caucus, Congressman Tom Reed is the co-chair of the Problem Solvers Caucus. He's one of the people I really like, and is a member of the House Ways and Means Committee. We have a lot of problems to fix. So let me start with Congresswoman DeGette, and I'm going to be a little silly for the moment because I just love Christmas trees. Congratulations, Colorado, according to your Twitter, is going to be providing the Christmas tree at the Capitol coming in, and I know folks can go see it in Denver. So, whatever thoughts you have on that. But then I'd just like to ask both of you, in a problem solvers mode, and, I've talked to Fred Upton, many on the Republican side, Congresswoman DeGette, about the importance of that 21st Century Cures Act. We've talked about it today as well, about being the Operation Warp Speed equivalent in a lot of areas. So I'd just like to hear from you both. What needles do we need to move on diabetes that aren't being moved? What problems can be solved as we come into a new Congress?
Well, thank you for having us. And of course, we're always proud when we get the Christmas tree. This is not the first time. What?
Do you ever not get it? Does Colorado not get it?
Sometimes we let somebody else have it, but I will say we've had it more than once that I've been in Congress, and it's a big honor, so it'll be fun. I was really proud. I work a lot across the aisle, and I'm really happy that you're doing this bipartisan dive, because I think in the next Congress, and I'll bet you Tom will agree with me, it's going to be even more important to forge these bipartisan partnerships to solve these issues. Fred and I did sponsor the 21st Century Cures Act, and we think that this can be a model of how we expedite research at the NIH and of course at the NIDDK and the other institutes, and then how we approve drugs and devices at the FDA. Fred and I are working on Cures 2.0 right now, and one thing that we hope to include in the next piece of legislation is expedited review by CMS of drugs and devices, because of course if CMS doesn't cover it, then it really doesn't make a difference. And what we've seen in the diabetes realm in particular is a very slow process at the CMS for approving technologies, which really limits the access of diabetics to get the current standard of care. There's a lot more that we can work on, but that's going to be a big focus of the legislation Fred and I are going to be introducing soon in the next session.
Representative Reed, do you agree with that on the regulatory? Because, part of this, as I look at it, there's the cost side and the patients and focusing on, patient health and what they need. Another part of it is science and innovation. And there are just unbelievable blockages in both of those areas, it seems to me as an outsider. But I'd love to get your comments on what Congresswoman DeGette just said, and then also see what's on your playbook to understand, because I know that this is personal for you. And would love to know what you think we need to do coming into the next Congress.
Well, I appreciate being here with you, Steve, and couldn't ask for a better partner on the diabetes caucus than Diana DeGette. We work so closely and well together on these issues. Both parents of type 1 diabetics have been living with diabetes our entire lifetimes, it seems like, at least our children's entire lifetime. But, what she's talking about is absolutely something we need to do a much better job at. And I think there's bipartisan agreement for it, which is, as that innovation, as that science comes through with breakthrough technology and breakthrough treatments, you match up not only getting it approved and reviewed from a scientific FDA point of view, but making sure that the insurance and CMS and the other agencies are there at these takeoffs so that it's accessible to people across the country. And I think we can do a much better job there. I wholeheartedly support what Diana and Fred are doing in regards to that. And we look forward to streamlining that process. But I would also, I'm the eternal optimist, Steve, as you know. And, I look at COVID-19, for example, and I try to look at the silver linings out of such a horrific experience that we've gone through as a country. And when you see what we've done with telemedicine during COVID-19, what you've seen, what we've done with accessing some of the innovation and getting it through the red tape in a much better and quicker fashion, I think there's bipartisan agreement that we can build off that success that COVID-19 showed when it came to accessing medicine through technology, through telemedicine, things like that. I think there's an opportunity in the next Congress to solidify that. And that's only going to help, in particular, diabetic patients. When you look at what has happened with losing connection with their caregivers during the crisis, and you know what happens when you lose that connection, especially with diabetic patients. If you don't have that follow-up care, if you're not monitoring those A1Cs, if you're not monitoring access to insulin and things like that, and good nutritional training, you have compounding corresponding comorbidities that start to set in that we can avoid. That's not only a bean counter cost issue, that is a quality of life issue that has to be recognized. So I think there's some opportunity there.
So I'm very worried about ruining the goodwill of our conversation right now by asking you both about health insurance. But another important dimension for a lot of people who have this chronic condition is that a lot of Americans, let's just presume they have health care. A lot of them have high deductible. And when you kind of look at, the anger of a lot of Americans with whatever, conditions they may have, they in some ways saw what they saw with the expensive price of drugs, but it got conflated as well with high deductibles. Is there any chance that the parties can come together and look at safe harbors on some of these necessary drugs in a way that can escape some of the drama, if you will, of what's happening with the increasing costs of out-of-pocket expenses of Americans with diabetes? Let me start with you, Diana, and then jump to Tom.
Sure. Well. So I don't think that having affordable health insurance should be a partisan issue. I think Tom and I will both agree that we need to make sure that people who have that health insurance can afford it. So I know we'll have conversations about what to do about these high deductible plans. In the meantime, Tom and I have a bill, which I expect we will reintroduce in the next Congress, and it's getting momentum, the Insulin Price Reduction Act. And this is a bipartisan bicameral bill that's targeted at reducing insulin prices so that everybody can get their insulin. Almost every family who has someone who's diabetic knows what it's like to have a high insulin bill. And the way that these prices have increased in the last number of years is just it's just unacceptable. And so I actually think as we talk about insurance that people can afford, if we talk about affordable prescription drug prices, this is actually a bipartisan sweet spot. And Tom and I both think that we could use this as a jumping off point to get really meaningful drug pricing reform.
God, you boys are so reasonable. This is Tom.
It's beyond belief.
Tom Reed, I thought I was going to be breaking up the fun here, but I mean, because what I'm hearing from you is that there's a lot of consensus about trying to address these costs. Because I just see, and I do a lot of these programs about healthcare costs, and I know there's an ecosystem of folks with a mix of white hats and black hats in that mix in terms of how a drug gets a price. But I'm interested in what you think we need to do with people who are feeling very, very high out-of-pocket expenses for these life necessary drugs. Tom?
Steve, I couldn't say it better than there's a lot of agreement here that Diane and I have worked together for years on, and it was the Diabetes Caucus, if you recall, that did a 2-year study working together behind the scenes on PBMs and pharmaceutical companies and really pulling the curtain back and bringing sunshine as to how those negotiations work and how folks that get the rebate benefits, it doesn't really work its way all the way through to the end patient, to the end user of the system. And so there's a lot of support for trying to hold accountable that pricing structure that we've created. And some would argue, and some rightfully so, that what we did is we created a market, a system that had the unintended consequence of having all these perverse incentives to have all these list prices just go through the roof because there's no cost containment strategy. There's no benefit to negotiating truly down the prices. The benefit is all by negotiating the prices up by all the people in the room negotiating and setting these prices. And that report, I think, started this conversation on drug pricing in a way that set the stage for the bigger question that Diane and I are always wrestling with, and that is how to get drug prices down, how to get access to those drug prices or those drugs in an affordable way. And there's a lot of agreement here that when we talk about rebates, for example, passing those rebates to, I'm working with Senator Wyden as well as a bipartisan effort there, passing those rebate benefits, not to the pharmaceutical and the PBMs and the pharmacies themselves, but to the patients, having them be the benefit of those dollars. And, we've been talking to a lot of the diabetic patients out there, because we put this sunshine on this whole area of insulin pricing. I was just on the phone with Lilly yesterday, the USA director of insulin. Each one of these manufacturers have programs now where they cap the out-of-pocket expenses, and Lilly is $35, consistent with the federal standard that came out from the administration, so that we can get insulin delivered to people at no more than $35 a month out-of-pocket expenses. That is a good move. Now, I told them we need to raise awareness. We need to make sure people are aware that that's out there and get more access to it. And that's obviously something that work with us on, but they don't want to go too quick there.
I want to ask you sort of a naive kind of, out of left field question before we go to the audience. We have my friend Marty Bell, who's been very supportive and helpful in today's event, who wants to pose a question. But you both have children with type 1 diabetes. You're both in the helped lead the Diabetes Caucus. You believe in science. I didn't know, and I said this at the beginning of the program today, I didn't realize how prevalent and how large a footprint diabetes was in my circles, in my neighborhood, among my friends, even in my family. It just wasn't something I was aware of. I am now much more aware of it, and I confessed my ignorance to a lot of this. But I am interested in what you do to generate empathy among your colleagues, understanding among your colleagues about the priority and importance of this. If one is not aware that just around them, if they scratch beneath the surface of their friends, their community, their broader family, that this is out there in ways that they might not even understand. Because, I understand people who experience it for themselves. But if they haven't done that, how do you kind of bridge that lack of awareness and understanding among your colleagues? Diana?
Well, let me just say, the Diabetes Caucus historically has been the largest issue-based caucus in the U.S. Congress, well over 300 members, because every member of Congress is touched by diabetes in some ways, type 1, type 2, pre-diabetes. And so the Diabetes Caucus spends a lot of its time educating our members about different issues, but it's also why we get the power to do things like pass the Special Diabetes Fund, which has funding for type 1 diabetes and also type 2 diabetes research among Native American populations. I'll just tell you a quick anecdote. I think that most of our colleagues know now that Tom and I have kids who have type 1 diabetes. And one time we were having a hearing in Energy and Commerce, and a witness was talking about, we were advocating for the low blood sugar, low glucose cutoff insulin pumps. And a witness was testifying about how sometimes if people's blood sugar drops really low at night, they die. And she says, we call this dead in bed. About members came running over to me, including Republicans and Democrats, and they
We may be losing Congresswoman DeGette.
And just a few minutes later, the pump was off. So, just know really help the members of Congress understand it. I'll just quickly put in a quick commercial plug here. This is why we lobby as a cause. And here, we really need the continuity of research.
Congresswoman DeGette, we're having a little bit of trouble. I'm going to come back to you in a moment to do your commercial plug. Let me ask Congressman Reed just for a quick comment before we go to our question.
Yeah, no, being the father of a type 1 diabetic gives you that personal experience that you can go to members, because we hear it all the time.
Sure.
We still get people like, oh, they'll outgrow it, or, haven't they cured that disease? Yeah. Haven't they figured out a way that you can live with diabetes and it's not a problem? And it just reinforces the need to raise awareness on the issue and raise awareness that, diabetes, we do want it to be a thing of the past. We do want it to be a historic footnote where we celebrate the success of curing it, but we're not there yet. And we tell the story, and once you tell a fellow member about your son or your daughter or a personal experience, I will tell you, it carries a lot of weight to those members, because now they see you in a different light. And it also gives you credibility on the issue that I think other members maybe don't have as much of a credibility.
Well, I'm glad to hear it, because I do think awareness is part of the game, and I'm glad you're doing it. Diana, you went out just as you were offering your commercial plug, and I want to give your commercial pluggee that opportunity. Go right back to it.
I was just going to say, we need to reauthorize the Special Diabetes Fund for a 5-year period, because we have to have the continuity of research. We can't just keep doing short-term fixes. And I think with the numbers that we have, we should be able to do that.
Well, thank you. Let me go to Marty Bell. A question from Marty, who was helpful today. Marty?
Hi, Steve. It's Marty Bell. I'm the father of Olivia, who has T1D. I'm also a huge fan and supporter of JDRF and, like Congresswoman DeGette, a proud graduate of NYU Law. I have a question about the Special Diabetes Program. I'd like to know how we get back to funding it for 2-year increments. While the continuing resolutions of 3 and 6 months are certainly appreciated, they're really inadequate, because scientists and labs require some certainty of funding if they're going to do the research that we all hope is going to someday, hopefully soon, get us a cure for type 1. Thank you.
Representative DeGette, I should have had Marty ask you the question before you said that, but any more thoughts on the Special Diabetes Fund?
Right.
I think we've lost Diana, so let's go to Tom Reed. Congressman Reed?
Yeah, I think you're absolutely right on to it. And Diana and I totally agree. Did she come back? I totally agree with that.
I guess we are. Well, I just want to thank you both. I think we're right at the point where I think we're all in vigorous agreement. And thank you, Marty, for that question. Diana, I see you there and you look great. Do you want to add a final comment, because you got cut off because of the bandwidth, and I apologize.
All I wanted to say is it's a top priority of ours to reauthorize the Special Diabetes Fund. Also, excuse me, I just learned it's Tom Reed's birthday. So happy birthday, Tom.
Okay. Congressman Reed, happy birthday. I want to thank you both, Diana DeGette, Tom Reed, members of the Congressional Diabetes Caucus. I hope you'll come back and talk about this. And as I told really excellent panelists earlier, I hope we can continue to come together and talk about the importance of this, but also mark progress or mark lack of progress, because I think what you're doing is so important. Thank you so much for joining us today.
Thank you, Steve.
That brings us to the end of our program today. A big thank you to the Diabetes Leadership Council and Diabetes Patient Advocacy Coalition for their support, and to all of you attendees for joining us for this set of important discussions. If you missed any of the conversations, we're going to have a video up shortly of the event, and you can go to our website this afternoon. For those interested in continuing the discussion, join us in just 1 hour at 2 p.m. Eastern Time for Technology and Diabetes Care, a fascinating look at how technological advances are improving the quality of life for patients. With diabetes, I'll be there. I'll be joined by Representatives Michael Burgess and Robin Kelly. You'll find more info on thehill.com/events. It's not too late to sign up for the live stream, or you can just watch it. I shouldn't tell you that, but you can just watch it as well. Until then, I'm Steve Clemens. Be well.